Hi, everybody. Welcome to the first lecture of Fire 112A. I'm your intrepid instructor, Ken Allen. I'm going to give you most of these lectures online. You'll be able to watch them, ideally, at least listen to them if you don't have the computer or the screen to do so. The majority of our lecture will be through the podcasting or the learning management system, the Canvas site. These are all also on YouTube, so you should be able to pipe in at any place at any time on any device and listen to these and watch. And the goal is that you have this at your disposal, plus the text, as well as the home quizzes and the keywords and terms, and 4 other instructors at your disposal to ask questions, to volunteer for scenarios, to hone your skills with the different psychomotor management assessment skills that we have to do, things like medication administration, patient care, medical patient assessments, learning a head to toe, physical assessment, and so forth. And all of the time in class to do this in real time and take the information that you're learning here from the lectures and the books and apply that to an actual patient in a scenario where everyone's watching. You're needing to deal with your own anxiety and face whatever the emergency happens to be and make the right decisions to save that patient. It can be a little bit overwhelming. That's the point. I want it to be stressful. Don't feel like you're getting picked on. Feel like you're lucky enough to face the stress before the actual storm of reality hits you. Whatever walk of medicine you go into, you will be facing life and death. And this is your first foray into it to figure out, how does it make you feel? Where do you get most timid? Where do you find yourself pulling back? Where are your strong points? And where are the things you need to work on? And really, in this environment, it's pretty harmless. You're not going to really hurt anybody. The only thing you have to worry about is your own fear and anxiety. And if you can get the best of yourself, then you're going to get the best out of this class. I don't want to keep talking. I just want you to realize that this should be with you along the way, but there's another whole portion of the class. The most fun part will be while we're in class running scenarios with fake blood and guts and people acting and everything else. And so before we get into any of that, we got to know what it is to be an EMT, what an EMS system is, and where the EMT is in that system. And then lastly, is this the right career for you? So let's take a look at this now and move forward in our lecture. So an EMS system is what we would consider how we manage a sudden emergency medical or trauma issues. Patients that have suddenly stopped having a heartbeat or have fallen from two-story building and hit their heads. And now they require emergency care. Once emergency care is needed, the EMS, Emergency Medical Services System, will be activated. And there are a number of different people of different ranks and training that will come into play, from the dispatchers that first field the calls to the police and the fire and the EMS units that are around, and to the captains and the officers that are in charge of it all, that help everything run smoothly. And above that would be the administrators and the people making these plans and making the plans for the future. So come along with me. Let's take a look at what will be covered in this lecture. We'll talk about the system in action. And by that, it would be, let's say, the 911 system, for example. What happens when you make a call to the 911 dispatcher? History of emergency response, fire, EMS, included roles and responsibilities of EMS workers, what it is to be a professional in this, not just monetarily or formally working a job, but what kind of ethos, what kind of ethics and morals should you possess to be your best? What's the modern infrastructure look like in a 911 system? Quality improvement. How are these things in the structure, in the infrastructure, then honed, analyzed, streamlined, and made better? Protocols and priorities, specifically to EMTs. We'll talk about what we call basic life support, which is what you are trained in providing. Patient safety, how to manage your patients safely, how to treat and transport your patients safely, how to be a patient advocate, and you being the best EMT. So, what is an EMS system? What's an EMS system composed of? And where is the EMT's place in that system? These are common questions that not only most students have, but we find them on quizzes and tests. So also pay attention for that portion of the need to know. It's a team of healthcare professionals of varying degrees and certifications. What's that mean? Well, you're already trained as EMRs. You're now being trained as EMTs. There are paramedics in this EMS system. At the hospital, there are nurses and doctors. At the administrative branch, there are people that are CEOs, there are chiefs, presidents, governors, and so forth. And there are people that have been appointed by the state and by the federal government to oversee all of this. They provide emergency care and transport for patients in extremis, which simply means you're hurt really bad. And all of this is then governed and overseen by state laws and federal agencies. So everything from the firefighters first getting on scene to the patient leaving the hospital, this is the EMS system. It all begins with reporting. You are a massive part of that from here on out. Understand your place in the chain of survival. The chain of survival is simply the linking of the different agencies of EMS. From the moment the injury first occurs, someone needs to contact 911, which puts the ball in motion for 911 to dispatch an emergency crew to show up and start providing immediate care, possibly treatment with other devices and techniques like defibrillation or pacing or splinting, packaging that patient, rapid transport of that patient via ambulance to the hospital. And then in the hospital, the provision of advanced life support through doctors and what we call definitive care. Definitive care means the care that will keep them alive for years to come. Definitive care typically means surgical care, surgical intervention. You're going with that patient once they're delivered to the hospital to the operating room, and they are then being operated upon. They're buttoning up bleeds, removing damaged tissue, putting them on cardiac bypass. Definitive care is really our goal from the time of injury to the time they get to the hospital. Our goal is how quickly can we minimize this period while still providing enough care to the patient to keep them optimal and alive for the delivery to the operating room. You, from here on out, should always be the one that contacts 911 if you see an emergency. You also now have the choice of whether or not to be a caregiver in that emergency. You can step in and start providing basic life support. And the more confident you become in this class, the more courageous I hope you become in actually helping a patient, as long as it's safe enough and that you feel that you can provide some good. I'm going to tell you, you're going to be better at this than any civilian. So don't hesitate to step in. That moment that you first call, dispatch and reporting gets the information. And this is what we call the activation of the golden hour of emergency care, from the moment of injury to the moment of surgery. At a comm center, a dispatcher is going to dispatch whoever is needed for that emergency. And it goes in this priority. The first dispatcher you reach on a 911 phone line is a police department dispatcher. For their first priority is, do you need a police officer there with a firearm because your life is in danger? Is there any possible danger to life and health where an active member of the police department with their firearms would be the most beneficial person arriving on scene? And if so, police will dispatch the closest unit or units to that call. That individual will then be transferred over to the fire department's dispatchers, and those dispatchers will then dispatch the nearest fire engine or trucks or apparatus that are needed for that emergency. And lastly, EMS, if it's a separate division, if it's a private agency, will then also be contacted, and they will send the closest unit to that emergency as well. And typically, that's how you see people arriving on all of these calls, including medical calls. This is why we train firefighters as EMTs and paramedics, because believe it or not, there are a lot more fire stations per capita than there are at any time a roaming EMS ambulance. And so you need to make sure you get to this patient soon to stabilize, to package, and to get this patient ready for transport. That's really fire's main goal on medical calls: patient stabilization, patient packaging, and treatment, and readying the patient for the emergency transportation by an ambulance. But it doesn't mean that's always the way it works. Sometimes EMS are the first to show up on a freeway accident, and there are no police to stop traffic, and there are no firefighters putting cones up. So don't take all of this as given. It could always change. Life is unpredictable. We need to be able to move and dodge the punches and figure out how to improvise whenever possible. So the first responders that arrive, usually, as I said, PD, are EMRs. So you're already trained in what they know. However, they're usually not doing any kind of medical care. The police officer's first role on scene is traffic control. And so very often they're trying to move cars off the freeway to get traffic going. They're constantly asking crews, how quickly can we move this car? Is it possible to move the patient out of the car so we can push this car to the side? Their goal on most issues, as long as it's not the need for firearms and protection, is traffic control. Sometimes you'll see them pull out, let's say, Narcan for an OD patient. That's usually in a rural setting where there's not a lot of ambulances or fire departments that close. When the fire departments show up, the fire crews are going to do patient packaging, treating, and stabilization. And that's because, well, the EMS crews, when they show up, their biggest tool is this big toolbox. It's this big ambulance. Really, we want to make sure this thing is intact. So when when we get on calls where there's traffic or there's issues, make sure that ambulance is well taken care of and it's prepared and ready to transport as soon as the patient is placed in there, particularly if this is a load and go unstable patient. And we'll talk a little bit about that later. So in an ambulance service, we have different people working in it. It could be EMT ones, it could be advanced EMTs. We don't have many of those in California, if we have any. Or it could be paramedics or some complement therein. It could be a dual medic. It could be one EMT, one paramedic. It depends on the agency, it depends on the county, and it depends on the protocols. If it's two EMTs working on that ambulance, then that ambulance is considered a basic life support unit. It's usually not a 911 unit, meaning it's not tied to 911 dispatching. And they're typically doing code 2 transfers, maybe a patient from home to the dialysis clinic and back. They're a patient that's medically ill or injured, but they're not going to die. but they still need medical supervision. It could also be the delivering of a patient from a hospital 30 miles from where they live to a hospital 2 miles from where they live. The ambulance will go pick up that patient from that hospital in the ambulance, put them in a gurney, have them on their medical devices, and drive them over to the nearest hospital to the patient. That's called interfacility transport. A lot of ambulance agencies start their EMTs off as interfacility transporters on a BLS non-911 rig, and then bounce you up into a one-in-one EMT medic advanced life support ambulance. And whenever you see an ambulance going lights and sirens, 99% of the time, that is an ALS, an advanced life support ambulance with the paramedic on board. Advanced life support is all of the bells and whistles and cool technology and treatments that we have at our disposal in a 911 system. You have the IV ability with all of the drugs that can be given. You have not just AED or defibrillation, but you have the ability to shock patients that are conscious. You can speed a heart up by creating external pacemaker. You can give an extended different treatments like cricothyrotomies and pleural decompressions, essentially putting a needle inside the chest and re-expanding a collapsed lung, or cutting into the trachea or putting a large bore IV in there. If there's massive facial trauma or swelling or burns or something, you can access their airway at the throat down. These are all the really cool jobs that paramedics get to have. And they are all part of that protocol that allows them to work on an ALS rig, on an ALS ambulance in a 911 system. So who gets dispatched? Well, it depends on whatever is the need on this, as you can tell. It might be an engine in a truck company, especially if it's a fire, that's what you're going to get. You're going to get a fire truck, fire engine. If you don't know the difference, fire engines generally have hoses and water, and fire trucks have all the ladders and the tools, and they have different jobs on fires. You could also get specialty units like rescue squads, where if, let's say, someone's trapped on a roller coaster and you need to find a way up into there, or there's an issue on a BART derailment in a subterranean station, the rescue squad specializes in managing these unusual emergencies. It could be an issue with some kind of caustic chemical, in which case hazmat will also be dispatched. PG&E often is an additional resource that's called for, of course, an ambulance and PD. And always understand, if you feel the need for another resource, as long as you have a radio with you and you have communication with dispatch, you can always call for another additional resource if need be. A lot of times things like animal control are required. Bariatric units for very large patients. We have to find a way to bring them to the hospital. We don't have the weight capacity on regular ambulance gurneys. The next part of the chain of survival are all of these specialized treatment facilities. Things like trauma centers, spinal cord injury centers, cardiac centers for STEMIs or heart attacks, stroke centers, burn centers, pediatric units, specializing in perinatal centers like OB and childbirth. Later on, once the patient's been stabilized, can they go to a hand center, a place where they can get continual specialty care? These are all things that you'll learn as you go through this job and you complete your training with different fire and EMS agencies. You'll learn where these different care centers are. You'll learn more on the job what your importance is. And truly, we're the backbone of EMS. EMTs are the unappreciated, underslept, overworked majority of caregivers that work in hospitals and work in ambulances and fire departments. And if you're not getting blood pressures, putting the patient on oxygen, applying a splint, putting them on a gurney, then you're managing crowd control, you're moving things out of the way in order for the gurney to get through the door and away from all the pots or the junk that's in the way. You're getting the ambulance prepped and opening the doors and making sure that all of the supplies get restocked. It doesn't run without EMTs. And so understand that this is kind of the low end, the grunt work where everything is a proving ground. So welcome to the club. It gets hard and it gets a lot better from here on up. So let's take a look at where all of this began. The origins of emergency response kind of delve into two main categories, of medical and then like emergency trauma care and transportation. So if you want to look at the medical aspect of this, it would be things like village nurses or shamans, midwives, village healers. In fact, and this is one of the places they think they got the staff of life. There's this worm in Africa that is deadly toxic, and you have to take it out slowly, otherwise it will break and poison the host. Thus, you take a stick and wrap it a turn every day or so in order to slowly remove it from under the skin. And this is one of the impetus for where they think the origin of the star of life with the snake on the staff comes from. There's also biblical connotations to this as well. There's the story of Moses in the desert with the Jews, but this is a good story. I like going with it because it's pretty cool. How it looks just like that worm on the stick. Well, here's another one like that. The Knights of Malta, where these knights from Malta, along with pursuing the Crusades and managing and being in armies and so forth, and guarding the Holy Land, they also would take care of injured knights and soldiers in battle, and they'd pull them away and do some kind of field care for them. Well, this is the Maltese Cross. I'm sure you've heard of the Knights of the Maltese Cross that comes from the Knights of Malta. And it's actually where firefighters get the modern day Maltese Cross that follows in that same tradition of managing emergencies and the people that have been affected therein. So that idea, think of it as the years progress, and most of the time, emergency care gets better, or the evolution of it occurs during major battles. And so most of the time, modern surgeries and things that modern doctors, how they would get their experience would be by following an army and doing care throughout the battlefield and taking care of it. And so you have things like the Civil War, field hospitals and surgery was, pretty barbaric. Even before that, you have the Napoleonic Wars, where Napoleon's armies would go and there would be doctors and a group of soldiers, and they would do what's called triaging. They would look at the severity of each injury, decide which soldiers could live, which soldiers were going to die, which soldiers needed to be pulled off the battlefield first. And they would take them off in this little conveyance here, the ambulance in the back of the horse. I'll show you a picture of that. So this would be presumably where the patient sat. A bit of a bumpy ride, wouldn't you say? Horse drawn, and there's people being carried by other men here, running off the battlefield. They revolutionized how quickly they could do battlefield surgeries, like amputations, essentially. How quickly could they cut off a limb because it had been pulverized by a cannon shot? Or if days later it became infected, it had to be amputated. Otherwise, the gangrene would spread through the soldier and kill them. So there were doctors that would brag about the fact that they could amputate a limb and take care of all of the bleeding within 2 minutes. So they would tell soldiers, they'd give them a bullet, say, bite the bullet. That's where that term comes from. Or they'd give them a leather strap, put it in their mouth and tell them to bite down until they passed out from pain. If you were lucky enough to have alcohol, you could drink and pass out. And the very lucky could receive morphine, but morphine was at a very high shortage at that point in American history. So you basically had to bite the bullet. But that rickety horse-drawn ambulance eventually got modernized into an ambulance with air inflatable tires and a pretty decent sized rear compartment. Even better, a faster ambulance that could get the patient from the trenches in World War I to the nearest area where they were conducting battlefield care. Also, in those hospitals, there would be a little bit better surgery. They did have general anesthetic. It was usually ether back then, and they could knock you out and provide what kind of care. The actual surgical quality was questionable. It does get exponentially better by World War II, where now you have battlefield medics, you have the ability to handle plasma and give morphine, either intramuscular or IV. And then think about the distances that these GPVs can go, these general purpose vehicles. That's where they get the term Jeep. They could drive now miles away from the battlefront to possibly a large church or a convention center or an actual hospital that was in the nearby town where you could have doctors and nurses stationed there to do modern care and surgery. You also have the addition of antibiotics like penicillin, which was a massive savior for soldiers. And this understanding of the hour from injury to the time they make it to the hospital is critical in the survival of that patient. And if we could deliver, if a soldier could be delivered to the hospital still alive with their wounds packaged and stabilized, and they were alive by the time they got into the operating room, chances are they're going to survive. So we realized that there's about an hour that we have to keep these people alive. And that starts to become ingrained in our brain. Rapid treatment, stabilize, rapid transport. This gets even better in Vietnam and Korea when you get helicopters that can now go not 5 or 10 miles, they can go 50 miles, they can go 70 miles, deliver that patient within an hour to an actual functioning hospital somewhere in a military base or in a city where you have doctors and nurses and all the modern conveniences. And if you've ever seen what the military base hospitals look like now, they're the amount of surgery and the care and even the equipment like CT scanners and MRIs, it's almost exactly what you would get here in the States. And this idea is if we can get them from the injury to the surgical area, no matter how many miles away that is, if it's in an hour and they're alive when they get there, chances are they're going to survive. And we've become more elaborate with care. We've become a little more elaborate with the treatment we do on scene. To an extent, you don't want to waste too much time on scene, but the delivery of a survivable patient has become greater and greater and greater along with modern technology. And we see that through modern war. Sometimes we see it through things like pandemics. Let's take a look at these soldiers when they come back and why this now gets integrated into the civilian culture of America.
A reconversion of war plans to peacetime pursuits is going ahead at full speed. And once more, the automobile factories are humming as huge stamping presses form the bodies of the first automobiles produced since the spring of 1942. Prices on these 1946 models will be slightly higher. But with all priorities lifted, America will be on wheels once more. At the huge Willow Run factory in Michigan, where warplanes were made, the first new cars of the Chrysler Company are designed and built. The first models are made and are the forerunners of 26,000 which will be turned out under assembly line method. Mr. Kaiser produced hundreds of Liberty transport ships for the Allied war effort. Now he and Mr. Fraser present their peacetime product. The six-cylinder Kaiser car features wheel drive.
It had been a long, long time since Americans had been free to buy anything they wanted, but now the war was over. Cars, radios, cordless electric irons, consumer goods of all kinds were coming off the assembly lines. The Great Depression was just a memory. Most Americans had prospered during the war. They had money now, and they were eager to spend it. Many of the returning veterans got married. That created a demand for new houses and new kitchen appliances. Rationing had ended, food was plentiful. Overnight, it seemed, traditionally frugal Americans became conspicuous consumers. Nylons filled the shop windows, and real rubber tires rolled out of the factories for the new cars coming off the reconverted assembly lines. Americans climbed back into their automobile. With light hearts and no road maps, they headed off into a materialistic world of the future, never to return.
And that's where the trouble begins. So now, with all of these new freeways and the new big, shiny chrome cars with very little safety restraints and safety features baked into them, they go very fast on the freeway down long stretches where there's no lights, and they reach thousands of miles in straight lines, which has the tendency to make people pass out. And eventually we start seeing an incredible amount of freeway crashes, collisions, and death. And with these people hundreds of miles from nowhere in fatal crashes or very severe crashes, and no way to deliver them to the hospital, America started realizing something had to be done. And so with things like this, if you can't get that patient to the hospital within an hour, chances are they're going to die. And if there's no transportation and no care prior to that arrival at the hospital, there's really no sense in rushing them hundreds of miles to get them to the hospital because there's no chance of survival. So now we start seeing this information reaching the public's zeitgeist, realizing how bad these emergencies are on the freeways, and that something needs to be done about it. In 1966, there's a paper published called Accidental Death and Disability, the Neglected Disease of Modern Society. And it's talking about the abundance of freeway crashes, people dying, and they're dying alone on the freeways with no care or transportation ability to the hospitals. There's no chance for them to get any of this care. And we know that care works, having just been through World War I and II in that very century. So this is something that needs to now get translated into modern culture. There's an established explanation of why EMS or pre-hospital agency should be set up to focus directly on people being injured outside the hospital and needing emergency care and transportation to the hospital. A lot of it initially is trauma, but then again, this becomes more and more about serious medical as well as trauma issues. In 1970, the Department of Transportation, who's helming all of this simply because it's happening on freeways, and so it's the purview of the Department of Transportation, began to work on the first EMT training curriculum. In 1973, there's a Medical Services Act explaining the different protocols, the different jobs that will be for each training, for each level of training. And in 1971, the book that we're using, the American Association of Orthopedic Surgeons, published the first Orange book. They called it the Orange Book. If you look at your text now, you still see it's outlined in orange. It's the 12th incarnation of that book that initially started in 71. So we see other TV shows coming out showing all these cool emergency providers and what their job looks like, how sexy it is. Emergency showing up with Johnny and Roy, and they had a Rescue 51, this 2-man rescue unit, and they'd go and like rappel and save people that were hanging off of building ledges and pop off the IV, the epinephrine, and they'd be like pumping people full of amps of epi and atropine. And it was really cool first understanding of what this job was for the public. And they had people in the hospital and everything else. And movies like Mother Jugs and Speed, where it talks about how ambulance services operated in the old days before there wasn't designated ambulance service for each county. Ambulances were a free-for-all private agency. If you wanted to have an ambulance service, you could. Somebody else could have another competing ambulance service. You both listened to the police scanner, and when an accident occurred, you'd hear it get dispatched to the PD, and both of you would race lights and sirens to the call. First person to get there got that patient. You can imagine the amount of threat to the public, the amount of injuries that happened unnecessarily from people driving crazily to get to the patient, and the eventual need for us to say, okay, for each county, you're going to have one ambulance service that is the primary provider of care. They're going to be dispatched by 911. You don't self-dispatch, we dispatch you. Later on in the 80s, you see an advancement of ALS care, a slightly more protocol thinking service where we're now allowed to do in the field, deciding on our own, we're going to treat this cardiac arrest. In the old days, we had to use telemetry, which was essentially like a cordless fax machine for a medic to transmit the signal to the hospital, where a doctor would read it and say, this is cardiac arrest, shock the patient at this many joules, and provide epinephrine 1 milligram. And the medics would then have to do this back and forth. In the late 70s and 80s, medics are running the show. They have all the training that they require. They don't have to call hospital or base unless they need a question answered that they can't manage on their own. And so all of this treatment kind of becomes automated. It even becomes more automated with the advent of 911, which happens in the mid to late 80s, depending on where you live in the country. And then the agencies began to review how this has run since the 1970s. In the 80s, we start seeing the different regulating agencies reviewing the types of patients that are being treated, the types of care that's occurring, what treatment might need to be added for pre-hospital response, what treatment is unnecessary and might need to be taken away from paramedics. So as we start to see this automate itself, there's also regulating bodies that are looking at the agencies and looking at the infrastructure of EMS and deciding where can we cut corners, where can we add something that's required, and how can we make this a better functioning machine. And so in 2019, the latest agenda was released it's called the EMS Agenda 2050, a people-centered vision for future EMS. And the whole thing is like, it has to be a fully functioning recycling wheel. And so they actually make it look like a wheel. Adaptive and innovative, inherently safe and effective, integrated and seamless, reliable and prepared, socially equitable and sustainable and efficient. And all of these things have to be brought out, implemented, and then reviewed. And as we go through and we analyze the 911 system, we can continually add to and take away and, nip and tuck this thing into a better circulating or rolling ball down through the histories. So that means more rules and regulatory policies are being analyzed. We look at resource management. We look at human resources and training, and as well as equipment. What are we doing with our stocks? How often do we need to restock? What about our gear, our apparatus? How often do we get these maintained? What's the lifespan on these? Where do they go after they've been used for 20 or 30 years? Communication. What's the major radios we're going to be using? What are our frequencies? How do we gear our frequencies to work with the neighboring counties? And what happens if we go on strike teams with these counties? Do our radio communications work? And so these are all major concerns when you're looking at making something much more macro as it starts to fold out in between counties and then into the federal level when you're managing big disasters, wildfires, floods, hurricanes. Those things have to operate as seamlessly as a county. You have to have public information and dispatching and people at the hospital that can give you care, support facilities. They give you medical direction, trauma system development. How do we modernize and how do we speed up the process of transport and trauma care? Of course, education, which is what we're all a part of here, as well as evaluation. And all of this is now being, within 2050, we'll look back on these last 25 years and see how well did we do at modernizing this, at streamlining it, and what changes need to be made from here, 2050, to the end of the 21st century. So I'll leave that there. Take a look at that. And you can pause if you need to see all of those again. So that's essentially the EMS large system, the infrastructure of EMS. We can pause and talk about that. What was it? What all did we go through there? What was the whole thing, huh? So what did we see? EMS, system of healthcare providers of different training levels, giving advanced or basic life support on different apparatus, doing different jobs, all for the provision of saving a patient's life from the moment of injury or the moment of illness to the moment of operation or definitive care at the hospital. We want to do effective patient care. We want to stabilize, treat, package, and transport rapidly to a receiving hospital that specializes ideally in whatever this patient's illness or injury is. They can then be taken there and have a team of experts work on them and provide what? Definitive care for that patient to hopefully walk out of that hospital with a smile, with his family on his side, and live another 20 years, live another 30 years. Who knows? That's our goal in the modern EMS response system. And that's our main concern is we will activate the world to save one patient. It's pretty incredible when you think about it. It's really mankind at its best. You hear about how bad, but when you see this in action and you see someone trapped and everyone's arriving and there's news crews and that person is saved and transported to the hospital, it's a beautiful thing. And any firefighter, any EMS crew that's worked on these big emergencies and really severe calls and seen how well this can orchestrate, it's almost like a contact ballet. It's beautiful. It's really beautiful. Excuse me. I'm crying. I'm not. It's really an immense feeling when it's done right and the patient lives. And you realize if we didn't do what we do, that person would be dead. Let's talk a little bit about you now, shall we? If you want, take a break. Keep following me through. I'm going to keep going. So we have talked about the large scale stuff, but let's talk about you and call it the qualitative stuff that we should be thinking about. Small minutia, codes and code words that you should be aware of now going into the job. There's something called codes, code 2 and code 3. There's also something called a 10 code. We're getting away from that. I'll wait to explain that. Let's say you're working on an ambulance and someone calls dispatch and says, I think I broke my foot. Does that sound like a life-threatening emergency? You're right, it's not. So what they'll probably tell the ambulance crew is, please respond code 2 to 24 Mockingbird Lane. And the ambulance will drive from wherever they're stationed directly to 24 Mockingbird Lane and go treat that patient. They'll use their car without lights and sirens, and they'll drive according to the rules of the road directly to that call. They're not going to stop for coffee along the way. They're going to go directly to that call. That's code 2. There is a code 1. Police officers have code 1. It would be someone who calls the police department and says, I'm not sure if I locked my door before I left today. Can you go check? Well, at some point, the police officer will go to that house and check. But if he's managing code 2 and code 3 style calls, he's going to put that in its proper priority. That will be the last thing he does before he goes off or she goes off of shift. The big sexy one that everybody knows about is code 3. That is lights and that is sirens. And you are getting a prompt transport. Usually, this is how the fire department and the ambulances dispatch or travel to the emergency scene, just in case it's something severe. If you hear a patient is unconscious or a patient is lying on the ground, they could be sleeping or they could be dead. But since we don't know, let's assume they're dead and get there and then make that decision or find that assessment ourselves. But let's not delay and realize after we've driven 20 minutes in traffic, oh, we should have gone code 3 because this person's dead. So we travel from wherever we are, from the point of dispatch to the call with lights, with sirens. When you're driving, you should be in the far left lane and every car should pull to the right. If you see a fire engine or an ambulance behind you, pull to the right, pull to the right. We want to be on the left, so you pull to the right. Don't stop in the street. Don't go to the left. Don't panic. Just pull to the right. Okay. We get to the call. This is indeed a patient that is having heart problems. They're starting to die. They're sweating. Their heart's stopping. They're going unconscious. We're shocking them. We're giving meds. That patient needs to get to the hospital or they're going to die. You agree? This is what we would call a code 3 transport call. This means we're going to drive a little faster, maybe with a little more authority, getting people out of our way by honking, hitting the siren, and moving people away so we can get to that call faster. If there's a red light, we still need to stop, but we can proceed through that arterial, that intersection, as long as it's safe to go, as long as there's no intersecting traffic. You can even go in the opposite lanes if, again, you feel that they can see you within time and they're moving out of your way. That is how we drive most of the time 2 calls. And in some cases, if it is a severe patient, we will then go code 3 from their emergency scene to the hospital. The question is, how do we know if that patient's bad or good? Well, that's kind of the whole point of this class. So for now, I want you to consider ABCs. Always think of ABCs. When you get nervous in the class, step away and say ABCs. When you don't know what to do next, step away and say ABCs and make sure that A, their airway is open, B, they're breathing, and C, their circulation or their cardiovascular system is functioning. So in other words, are they breathing and their air, you can move air in and out. They're not choking or they're not sitting underneath a pool of water, and they have a heartbeat. And if they don't, we'll start thumping on their chest. If they have a heartbeat, well, what's their pulse? What's their blood pressure? Do we need to lay them down? What do we need to do with that? Let's get them to the hospital. And if we start to see that these ABCs are in some way flagging or failing, time to step it up and maybe go lights and sirens to the hospital. Here's a word about code words. In fact, we use code 3, code 2, not just in the way we drive literally to the hospital, but we'll sometimes call a patient, this is a code 3 patient, meaning like we got to go lights and sirens to the hospital. We'll also call those code 3 patients big sick, extremis, you heard that earlier, or this is a load and go. This is a load and go patient. After a brief assessment, treatment, and stabilization, if possible, we got to go directly to the hospital. That means we're unable to manage the life threats entirely on scene. They're starting to die, and we don't have the tools and we don't have the professionals there to manage the care required. By the way, the other side of load and go is what we call little sick or stay and play. And the majority of our calls are actually stay and plays. But we're going to train you on big sick, load and goes. That's what you need to be able to recognize. Those are the ones that will lose life if you're not paying attention. and they're going to get to the hospital to receive definitive care. So how do you decide the severity? Well, okay, if there's an unstabilized or damaged airway, if their breathing is out of sync or missing, or if their circulatory system or cardiovascular system is not functioning or functioning badly, they have irregular heartbeats, it's not beating at all, their blood pressure is sky high, or it is bottomed out and they're passing out, if their breathing is such that they're breathing too fast or not at all, or they're an asthma patient and they really can't breathe or even talk to you, if you walk in and you see them hunched over, breathing in a tripod position, these are signs that you should start to recognize that doesn't look good. Maybe we should go faster on this call. The hackles on your back should stand up. This whole animal intuition that you have been kind of pushing away in modern society, bring it back. It's now your best friend. Pay attention to the people in the corners of the room. Pay attention to the body language of our patient. Pay attention to what people are telling you and what people are not telling you. This all is a giant piece of emergency care and patient and provider safety. If we have unstable ABCs, or if we think, let's say that the time of transport, if it's a far distance, and if we speed that up, if that's going to mean the difference between life and death, then we're going to go code 3. Or does the hospital have the tools and the equipment and the surgical care that's required to save this patient's life? Then we're going to go code 3. We're going to get the heck off scene. We're going to apply vitamin. It's A, B, C, and D, which is diesel. You're going to put your foot on the gas of the engine and the ambulance and haul to the hospital. Okay. But even these patients that are unstable, that aren't doing well, we still have to assess them. You still have to treat, attempt to stabilize the issues that the patient is suffering from. And we still have to package them properly to get them to the hospital without having any further damage. So even on our load and goes, you are expected to do head to toes. You are expected to get an assessment, and you need to begin or entirely fix the unstable airway breathing or circulation if you can. And if you can't fix it on scene, get out of there. Some of these things we have learned as paramedics can be and need to be done immediately. And if you can't do it immediately, you probably shouldn't be a medic. But that also means get off scene and let somebody else take a crack at saving this patient's life. This class is going to focus on how much do you need to do on this patient to assess, treat, stabilize, and package on scene before you're now wasting time and you're decreasing this patient's chance of survival. So as we do this, we have our trauma bag, which is going to help bandage and splint. We have a medical bag that has blood pressure cuffs, stethoscopes. We have an oxygen bag. This is a demand valve setup here that I actually saw Captain Goodwin save a person's life with during my paramedic internship. It was my literal introduction to him. He rushed in with one of these and started filling up the patient's lungs, and they went from blueberry cyanotic blue to pink within about 45 seconds. It was a thing of beauty. Then you're going to, in addition to those basic life support bags and tools, have a whole complement of skills that you need to show in this class. You're going to need to show me, proper CPR and defibrillation, oxygen tank setup and delivery, medication administration or medication assistance, recognition of severe emergencies, knowing big sick from little sick, learning how to bandage and splint, that'll come in next semester, learning how to extricate and package a patient from car accidents, transportation to the ERs. We'll talk a little bit about that. We have an ambulance that we bring in, and you'll learn, what are the basic steps, but really the things to think about now are, do you know where the closest hospitals are in town, and which roads would you be taking depending on the time of day to get there? You have proper patient assessments that absolutely needs to be taught to you, coherent understanding of protocols, learning that some protocols change and you have to change with those as the training differs and advances, use of resources, and communication and documentation as always. And always you're communicating, you're learning how to best manage people that are you working along with. So teamwork, 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 teamwork. That's what we're going to stress going through this. Even if you're a lone wolf, you got to have a pack. You got to have a pack of wolves. And you will. You'll have your crews later on. We have the squads that will set up. As an EMT yourself, this class is going to train you how to manage a chaotic emergency. We do this through the simulation of scenarios where you come in and do just what we talked about on that previous slide. You do a patient assessment. You find their major issues, their injuries and their illnesses. You treat with basic equipment like oxygen and medication. You package that patient safely on a gurney and you get them to the hospital and give a radio report as to what you're bringing in to the hospital. That, while being observed by teachers and by your classmates, can be incredibly stressful. You will be feeling the stress. I can guarantee it. You should feel the stress. Lean into it. Feel that stress. Love it. Learn how to live in it, because a lot of that can be used to your benefit. And the more you start just accepting it and pile driving through it, the more you're learning how to manage stress in real life, when it's real stress that means the difference in your success or failure, or your life and your death, let alone the patient's life and death. And I'll tell you, if you give the attention and you put yourself in this class wholeheartedly, I will teach you, along with these other instructors, how to manage any emergency, how to manage any difficult situation for the first 15 to 30 minutes. You'll be able to at least have some control over your emotions, some poise, some logical thinking through whatever's going on, and you're going to be able to make a better decision tree. You'll be in there affecting change beneficially, better than anyone else that's on scene. If someone else comes up who's also trained, you're going to be a dynamic duo. It's incredible how this works. Give me the time. I will give you the solutions to this stuff. But really, you're going to give yourself the answers how to deal with this. My goal for you is to teach you things like how to improvise, how to manage stress, how to roll with the punches when you don't have medical equipment, how to multitask if needed, how to go and find other EMS providers for help or get bystanders. And if you're not the lead or you're not the highest trained person, what are the best things you should be doing in that scene to help out the emergency flow better? What procedures should you know what to do in certain cases? And really, it's just that balancing act of flowing in and out of an emergency scene while still providing beneficial care and input wherever you can. You're going to need to learn in this class how to operate mostly in an urban environment. But be aware that if you keep up on your training and you try other things, there are, hazmat crews, there's wildland EMS that you can look into. There are wilderness medicines. You can look into doing all of the confined space rescues and so forth. And so to always keep your options open. When you complete this class and the next class in spring, you will then be qualified to take a national exam. And when you pass that, you then are certified in the United States to work as an EMT. And then you put in that certification for California and you work in California and then into the county. That certification or that licensure works for 2 years. And after 2 years, you need to go and turn in paperwork on training to show that you have been keeping up on your drills, your skills, your literature, and continuing education hours need to be at least 24 to stay active in the state of California. We'll talk a lot about that as we go forward here, but it's your responsibility to keep your certification current. Stay on it, know when you're going to expire, and make sure you get your paperwork in beforehand. Keep your skills up to date and practice and train. What about ethically, attitude, conduct? What about that stuff? Well, I always think you want your EMTs to show up and look professional. Who would you want to see arriving at your house to treat you or your family members or your best friends? Be that person. Wear the right uniform, tuck it in. If you're a man, shave. If you're ratty haired and you look disheveled, you're not giving confidence to the people you're about to treat. Have the understanding that while you're on duty, you don't come first. It's another very important thing to keep in mind. While on shift, the patient comes first. The emergency comes first. Take yourself out of the most important role until hour 12 or hour 24 or hour 48. And then you can be the most self-absorbed person you want to be. But through that period of time, try and be observant, respectful of others. This is especially important, by the way, in spring when you go on actual ride-alongs with real ambulance agencies and fire departments. You need to be wearing the College of Marin uniform and looking your best as well as performing your best so that you paint us in the best light. Going through this job, I'll tell you, there's a lot of stress, physical and mental. And the best policies would be stay in shape, stay active, have some kind of physical exercise that you enjoy doing, be it running or dance or weightlifting or jujitsu, something that gets your body to move and kind of process the stuff that's been stacking on top of you as you go. I'm also an advocate of firefighters starting and EMS members starting mental health at the very onset of their careers, speaking with somebody at the very minimum on a yearly basis. As you go through another year of what you see and the trauma that you deal with, you should also keep track of the way that you're processing things. And so don't look at that as some kind of taboo. It's more and more the case that firefighters and EMS crews are managing by going to mental health and speaking to people because addiction, suicide, depression are all very real in this job. It's almost 3 or 4-fold with fire and police than the rest of the population. So keep yourself safe. And that means not just protecting yourself with gloves and masks and the right gear and staying away, but like keep yourself in good shape to face the maelstrom of this job. If you're dealing with hazards and things, have the right gear, have the right mindset to face all of this stuff. Eat right. A good diet is very much important. A good thing about the fire department nowadays is that we're eating very healthy and we eat as a crew. And so the whole crew's eating right. It can be tricky those first couple of years on an ambulance where you're sitting in a box all day and you're running and you're running and you're running. And the only thing you have time for is to stop at a fast food chain, grab a burrito or burger, and then you're off on the next call. It can be very trying on your body and your health. I'm going to just ask you to realize that. And on your off days or whenever possible on the job, try and bring in healthy food. Try and eat right when you can. And most importantly, think about getting some good sleep as you go forward. It's very important. We'll talk about that in just a minute. So as an EMT, be smart, make good decisions. When you're working with a crew, think outside the box and realize the best decision wins. Get rid of the ego. That'll make things easier in this class, and it'll make things certainly easier once you get into the job. You're there to just give your ideas, work out with the best idea that comes about to solve the problem, and move on with the situation in order to help the patient. Remember, what you do now, even in high school, will stay with you. So those infractions, those misdemeanors, and certainly felonies will always be on your record and will always be judged by whatever agency you want to work for. This also means whatever opinions you show on social media, those things will be evident, and they can look up your social media accounts to make sure that you aren't something that they don't approve of in one way or another. They're not going to want to see a high schooler drinking getting in fights, something that just paints you in a bad light. And certainly stay away from drinking and driving. If you haven't been told this 1,000 times, understand, even if you don't crash and hurt yourself or hurt someone else, if you get caught with a DUI, it's not necessarily a disqualifier, but you will always be in the runnings with people that don't have DUIs. And so you will always be a step down from the optimum employee that they want to hire. So start off in the right direction now. Don't drink and drive. Make good lifestyle decisions for yourself for longevity. The real only disqualifying thing would be a violent felony or a felony. Avoid breaking and entering and avoid fistfights. It's just good policy. Be honest, conduct yourself with integrity. Think about what you're doing for yourself. When you're taking care of patients, treat them as people, not patients. They're real people. Be kind, be generous, be a patient advocate. Make sure you're doing the best care you can for them. You're not tired, so you're skimping out on putting on all of the correct equipment. Do it all. Do it all, especially when you're tired. It's character building. Be motivated to get the job done and push a little bit harder for yourself and your patients. Remember, you are who you are when no one's watching. So if you're cutting corners because you don't think anybody's watching, you're a corner cutter. You're not going to become your best person. You have to get out there and push yourself. And that is going to make you better in the long run at getting your job, at promoting, at living longer, at being stronger, at being smarter, at being kinder. And that's the real big thing here. We want to become functioning human beings. Think about some kind of workout program. You don't have to be super cut up like this dude, but have a workout that works for you. And when you get into a profession where you have people you admire, officers, chiefs, captains, engineers, salty people that have worked there for decades, and they can show you around and tell you about the job, cotton on to them, listen to them, get their stories, figure out what they're doing and how they succeeded, and start to be inspired by that behavior and that person. There's nothing more somebody of that esteem likes than somebody saying, hey, I really respect where you've gotten. Can you show me what you did to get there? A lot of this, mentorship stuff starts as soon as you get on the line as a probie. And it goes all the way up from chiefs to division chiefs and division chiefs to department chiefs. So stay on that. Remember that this stuff all pays off in the end. Here's David Goggins, the craziest professional. What would you call him? Mega athlete. He runs ultra marathons, like 3 a week. He's a monster who just the switch clicked and he changed. And that was him before. And that's him after he decided no more excuses, get to work. Brene Brown, great story on how to manage stress and deal with your own resistance to perfection. And then in class, you're going to go over the self-authoring. We call it the self-alignment assignment, to kind of look at where you are in your life. Think about where you want to go. You're at the precipice of something giant. You're at that point in the cantina before you take off into outer space, and like in Star Wars: A New Hope. Like you're right at that little point where you're off to college and off into the world. So where are you now? Where do you want to be in 5 years? What turns you on, and what do you want to go towards as you get out of this class, in this school, in this town? And I based that self-alignment assignment on the self-authoring program. Lastly, understand you're not going to be flawless when you start this class. You're going to make a lot of mistakes. You're going to feel like an idiot, especially when you start running calls. And you'll be like, how did I forget that? I can't believe I forgot to do that. You will hear that, and you'll also hear our communication between the team could have been better. That is the common 2 things that you hear for the first half of the semester. Every team member forgets something very obvious, overlooks something, blanks out, lets the anxiety rise, has a breakdown, starts crying, Not really. It's about one person. Two people have cried. Says we could have done better. Feels angry, frustrated. That's the whole point of the class, dealing with the stress and being able to recall the subject matter while you're facing stress. Just understand that's how you're going to pass this class. Through the falls and the failures, you'll succeed. That's what this takes. So keep that in mind as we go forward. Basic idea is let's kill as many people as we can. Not like that, but in class. So that way we don't kill them in real life. Okay.
Dad, who are you talking to?
I'm doing a lecture for the EMT class, high school kids. I'm just talking to them. Look at this guy, EMT in training. All right, that's the end of EMS Systems. And thanks for listening. And please attend the next one, which is well-being, EMT wellness and well-being. All right.